Yes, sir.
Okay.
Sir, so the recording
All right.
is not. Yeah.
Okay. Now, normal growth. Now we know that growth is common to all living organisms, whether they are animals, whether they are plants or whatever. And growth means that there is hyperplasia, that is increase in the number of cells. Then there is hypertrophy, that is increase in the size, and then also differentiation, because we all know we start by a single cell, then we change the variety of cells, and they differentiate and forms different organs, as well as the cell sizes increase and we increase volume wise. So that will ultimately result in increase in the height and the weight, as well as changes in the body composition. Now, this is something which we also have to concentrate, because a lot of diseases have been identified related to the changes in the body composition. We can have a correct height, correct weight, but weight, of course, is just only a composite thing, and it will not differentiate various components, which I will discuss in the next lecture of assessment of growth. And then maturation and differentiation, because people will, or the organism will mature into different stages later. So growth is the main thing that differentiates pediatrics from adult medicine from a clinical perspective. So that is where we have to not only work with the diseases of the body, but also related to the growth, as much as clinical medicine works with the diseases, and then of course they will work on the other side of the life, where the geriatric component or with the degeneration. So like that, the two components have different uh, stages of growth affecting the individual, and pediatrics is mainly the increase in the size and differentiation and maturation. So fetal growth is now, although life we sometimes consider from the day that we come out of the mother's uterus into this world as the date of birth, but biologically, actually, the date of birth is the time you first conceive in the mother's uterus and forms into a embryo, then fetus, and then into the neonatal infant, like that. So you all may have heard what is called the first 1,000 days of life. That is starting not from the date of birth, or what we call as the conventional birthday, but the date where we were conceived. So in biological terms, we really don't know the date of birth of ourselves. It is so the first 270 days roughly we grow inside the mother's uterus, where we are totally dependent like a parasite. And then we come out of the uterus because it can't support us beyond a certain point. And then we will grow into uh, a, a differentiated being. And then till up 2 years of life, it is thought to, the next 730 days. So altogether, this first 1,000 days up to the completion of the second birthday is thought to be very crucial, because although we are what we are from a genetic point, the genes are really differently expressed to adjust to the environment. So the genes are not actually the gene. The same gene in different environment could express in a little bit of a different way in order to withstand the rigors of the environment. So that is what is basically happen. So in the first 1,000 days, that is what is important, because programming takes place during that period, and that will determine how we are going to function in the future till we die. So the fetal growth period is the most rapid growth period that we have in our life. And then it can be assessed through ultrasonographically, either measuring the crown heel length or the crown rump length. Rump means up to the buttocks, because sometimes the fetus may be keeping the legs flexed. So you can have different charts are there, and based on this, now they have prepared even fetal or the premature growth charts starting from 28 weeks onwards. Now the peak length velocity occurs during the 18 to 22 weeks of gestation, and the peak weight velocity occurs in the last trimester, somewhere around 34-35 weeks of gestation. So you can see different parts of the body develop at different times. So first 3 months, it's mainly, or the first trimester is differentiation into the organs. Then in the second trimester, it is increasing the lengthwise and causing the proportions. And then when it comes to the third trimester, it is mainly gaining the weight and depositing other nutrients like iron stores and things like that during that period. Now you can see this is how, with the gestational age, that the length begins to gain. So the distant charts means that how much cumulatively they have gained. Now velocity charts means during a unit time period, how much for that particular period the person has gained. So you can see that the peak about 20 millimeters per week rate, the infant grows or the fetus grows during this somewhere between 15 to 25 weeks of gestation. So you can see that this is, so at different times there will be. So these points will be accumulated or totaled, and then this distance chart will be made, where the distance chart means over the period of time how much they have traveled, whereas velocity means for a unit time period how much the individual has gained in that particular parameter. I hope you all are clear in the distance chart and the velocity chart, right? So please, if you don't understand anything, please interrupt and ask and get it clarified then and there, because it is easy. So during the last few weeks of pregnancy, weight gain is due to reduced due to. Then after last few weeks, that is maybe 38, 39, 40 or so, there may be some restriction in the gain of the weight, because the uterus will not provide adequate room. And also the placenta is a limited structure. There is an amount that you can provide, and beyond that, it can't support the fetus or the fetus. So what will happen is it will begin to plateau its growth, and then the baby will be delivered. So the restriction of the uterus, especially in the primary, it will be there because it is not a stretched uterus before, and then the child will find it difficult to expand, and then stops growth or reduce growth. So these are the physical environment is restricted, as well as the chemical environment where the nutrients are supported by the placenta, supplied by the placenta, can't maintain the required. It is just like somebody who wants to eat a large amount of food, but the stomach is not permitting. Like that, here, the amount that can be given per unit time is not maintainable to support a rapid growth. So it will ultimately come to a plateau. So after birth, the growth velocity gradually declines. So at birth, we have a very high growth velocity. For 6 months, it will gradually come down. And then after 1 year, it comes into a lower level. But of course, persistently growth happens, but not at the rate it was happening inside the uterus. Then, of course, if there had been a very, very severe restriction of the growth, then after coming out, the child may grow rapidly. For example, there can be a last few days, the placenta would have got detached or there would have been a large clot. So the placenta, although it has a large size, it was really functioning as a half-size placenta. Then, of course, there would have been restriction. Sometimes there may be changes inside the uterus. There could have been a large fibroid. So although the uterus volume seems to be quite normal, but the space provided to the baby will be restricted because there was a large fibroid, or there would have been a septum. You all would have learned congenital abnormalities, no? What is called a biconvate uterus. I hope you all know that. Is that so? You all have heard what is called a biconvate uterus? Hello? No one is there?
Yes, sir.
Yeah, because so that if you all don't know any word that I'm using, please interrupt and ask, because I'm assuming that you all know certain basic stuff, but I may have missed. So because of that, you have to let know. Then I can explain that. So if there was something jutting inside to the space or taking up the space of the uterus, then of course the baby will not be able to grow as the baby wishes. So there will be restrictions. So when the baby comes out, if the mother has enough milk, then they will grow on to the original capacity of the child. But otherwise, they will maintain on the same level. Now, factors that will affect in the birth weight and length are the birth order, height of the mother. If the mother is short, then the baby will be also small, because there is what is called the maternal restriction to the growth. Mother can't support. She is short means her nutritionally also may be small. Then her uterus may be small and her blood vessels all will be small. So she can't provide a large amount of nutrients to the baby. As I told you, the first birth order may also be small because the baby will be developing in a restricted amount of environment. The anterior abdominal wall, the uterus, they are all very, very thick and they are not being stretched before. Because of that, it will have some restriction. Then the weight gain during pregnancy. If the mother gains a good weight, then the birth weight and length will be good. That means it is a reflection of the nutritional intake of the mother. Then nutrition before and during pregnancy. So if the mother had been a poorly nourished mother, then of course she will have her own problems. And then during pregnancy also she gets low nutrients. She will not be able to support the baby adequately. Smoking and alcohol adversely affect the baby. Then genetics, you all know, large parents will have large babies, whereas small parents will have invariably small babies. Then the maternal illnesses like pregnancy-induced hypertension, which will have limitations in supply of nutrients to the baby. Then the diabetes. Diabetes can cause a small baby as well as a large baby. Then intrauterine period illnesses. If the mother gets certain infections like rubella, then the baby will not be growing and there will be issues in the infant. Now there are various factors which regulate the prenatal growth, and two main factors is the insulin-like growth factor 1 and 2. Then they actually share somewhat similarity between insulin. So insulin can bind to these can bind to insulin receptors and stimulate the growth. So IGF receptors, there are two types. High insulin concentration can bind to 1% affinity, both IGF-1 and IGF-2. Then IGF-2 binds with high affinity, but IGF with low affinity. You all don't have to know all this. If you know that there is the prenatal growth is mainly governed by insulin-like growth factor, and the insulin-like growth factor receptor, the insulin also can bind. And this is one of the reasons where If a diabetic mother is there, the diabetic mother will send a lot of glucose to the baby, and the baby will begin to secrete more insulin, and that insulin will go and stimulate the IGF receptors and stimulate the growth. So it is actually a diabetic mother's baby is not actually obese. He is not growing because he is getting directly large amounts of glucose, but actually the glucose which comes stimulate the insulin secretion, and that insulin causes the baby to grow truly. So his muscles, bone, his fat, everything proportionately grow. It is not that only one aspect that occurs. Then there are other different factors which will support certain parts of the body. Now, fibroblasts will help to grow the fibroblasts, epidermal growth factor, transforming growth factor, platelet-derived growth factor, nerve growth factor, like that. There are so many growth factors that they will stimulate the DNA synthesis, and the mitogenesis will occur in those individuals. So more cell proliferation will occur when there is more DNA synthesis taking place. So they have their own functions. You don't have to by heart all this, but just know that there are different growth factors that will potentiate the growth. Sorry. So the postnatal growth. So once the baby is born, then what will happen is the baby has to now, he is actually born in the sense he has changed his environment of growth from a total dependent growth to a semi-dependent growth, semi-dependent environment for the intrauterine, because he could not do anything. So he was just even not could swallow and take things. So that why the child was vascular-wise connected to the mother through the umbilical cord and the placenta. So it is a total 100% parasitic state. Now the baby is coming out from the uterus to the open environment and will have certain amount of liberties, and then also have certain amount of responsibility actually put on the baby to make sure that the child takes its own food and grow. So for that, there are reflexes. That's what basically the child will not, now he can't think and swallow and look for milk. So there are reflexes which would have been taught to you in the breastfeeding lecture, where there is, when the nipple touches the cheek, the baby looks at the breast, it will touch the upper lip, then the sprouting will take place, and then the mouth will open, and he will guide the nipple and through the nipple the breast into his mouth, and he will begin to suckle. So that way the child has a reflex to find the milk, but the mother's responsibility is to provide that. So within the first 2 years of growth, it is fairly rapid, but of course the rate is coming down, because extrauterine life, the first year of life, has the most rapid growth, and then later on again you will get another growth spurt during the pubertal period. But the first year of life, especially the first 6 months, has the most rapid growth, where the length increases by about 50%, and then the weight also doubles by 5 months. So you can see the rate is very high, but compared to the intrauterine life, it is actually low. And because of this growth happening outside, we will be able to see also growth-related various malformations also getting more and more predominant. And this postnatal part is predominantly nutrition dependent. And there are two main patterns that could be also seen, what is called a catch up and a catch down phenomena, which I will explain slowly. But otherwise, what happens is the child should continue the same growth trajectory within the after birth also. So that's, of course, there is a particular pattern which we will discuss little later, especially in the growth assessment, where they should maintain the same curve pattern. And if they are maintaining that, that is somewhat satisfactory, because they are just continuing the same level of growth that was happening inside the uterus or in the same pattern. So after 2 to 3 months, the child will usually, if there is a change in the trajectory, they will settle down if the initial trajectory had to be altered either by catch up or catch down. So you will understand a little later what I am telling you. So if you take this type of a chart, this is a baby who was born with a low birth weight. Now I am talking about a baby who was at term. Now the baby is born, but actually this baby could not grow because, not because baby's fault, but there was some issue with the mother's uterus. Maybe the mother's uterus was not enough in size, or there was a fibroid, biconvate uterus, or initially the baby was doing well, but last 2 to 3 weeks, the placenta did not function properly. So the last few days, weeks, where you all know that the child should gain weight over the last trimester, last few weeks after 32, 33 weeks. But during that period, the placenta was non-functioning. There was a detachment or there was a clot. So the baby did not get the weight. So he did not reach 2.5, 3 kilos, but remained somewhere around 1.5 or 2 kilos like this. Am I clear? Hello?
Yes, sir. Yes, sir.
Right.
Yes, sir.
Then gradually the child begin to recover. The mother's milk flow is okay. And you can see in about 2 to 3 months, the child has now settled onto a newer line, and with the mother's milk, their child is growing nicely. So this is actually, if there was no problem, the child would have had about 3.2, 3.1 birth weight. Now all babies should not have this catch-up growth, because sometimes people overfeed the babies and try to get a catch-up growth, which is also not very good, which again I will discuss in the other lecture, how to make sure that this new line is normal or not. We also have to think, because sometimes a baby will not have the potential. He is a very small baby, but we are overfeeding the baby and baby become obese even at this young age. So obese is not good, no, you all know that. So then what will happen? So we have to find out whether this growth is a good growth or not, which I will tell you in the assessment of growth. But this is what is called catch-up phenomena, where you are trying to gain what actually child should have been able to grow and then settling down. Now similarly, the catch down, where now the baby was born to a mother with diabetes mellitus. Large amounts of glucose was coming in. The baby's growth factors or insulin was increased, and as a result of that, the baby had grown in larger size. But actually, genetically, the child is not capable of growing at that rate, because his engine, his mechanism of metabolic processes are for a smaller baby. So then he will lose weight initially, but in about 2 to 3 weeks, actually, they will settle and they will move on to a new center. So if there was no diabetic, this baby also would have been something like a 3.2, 3.4 birth weight. But now what has happened is that the child is coming all because of the diabetes in the mother had a higher birth weight, but it is not appropriate to that baby, because by his mouth he can't take that much of nutrients. The mother's milk is also a rate limiting factor, and then he settles. So this is something what you have to remember in a diabetic mother. Sometimes in the history, the mother may say, no, I don't have diabetes. That is because we may have not been able to detect diabetes from our tests. But of course, if you ask whether the mother has any family history of type 2 diabetes, then they will say, okay, yes, my mother or my father does have diabetes. So that means genetically, this mother is prone to develop diabetes, and you all by now may have known that during pregnancy, sometimes diabetes will surface because with the other hormones and change in the physiology, they become little bit of diabetic prone, or their glycemic control will not be optimal. That is, so it's actually a warning about what is going to happen in the future. So if the mother does not take good care about herself, then she will not be able to control, and she will become diabetic also. So that way, there will be settling down into a newer trajectory. So this is also because sometimes some people will think that this mother is not producing enough milk, and trying to get into this level, they will artificially begin to start formula milk. And you all know by now, formula milk feeding is not a good thing. And actually this will lead to definitely making the child overweight, obese. So you have to know this. If a child has a birth weight in this country more than 3.5 kilograms, that means there is a high chance that the either mother had gestational diabetes, or mother has a strong family, not the father's side. The mother has a strong family history of diabetes, and then that has surfaced to some extent during pregnancy, may have not been a full-blown diabetic, because to diagnose diabetic, we have put cutoff values. And if they are not fulfilling the cutoff values, we will say no diabetic. But a hyperglycemic mother, which is now called as hyperglycemia of pregnancy, or what is called HOP, that they will be having very narrow levels of glucose in their blood. Their trough will not be 60 or 50 or 60 or 70 grams, but maybe 80, 90 during the fasting state. And the peak may have not gone beyond the level what we call diabetes, but of course substantially closer to that. So because of that, constantly the baby had been getting glucose, stimulated the insulin. Insulin made the baby large. Baby came out, but the baby can't sustain that on mother's milk, and his growth genetically also. So he settles onto a able line, which is this. So I hope by now you understand what is catch-up growth and catch-down growth. Then there are 3 phases of postnatal growth. That is infancy and early childhood, roughly up to about 3 years. It is mainly nutrition. Then childhood, growth hormone dependent. And then at the puberty, it is sex hormone dependent. So you can see how the height keeps on growing at different rates. It keeps on accumulating, and then they reach the final height, maybe 170 to 180 or so in between. Then you can see the velocity, the height velocity. So there was a very large velocity at birth, and you can see in the first 1 year of life, they gain 25 centimeters. So you can see roughly it's about this much. So then gradually they come down. They maintain a growth velocity because people keep on growing, and then gradually comes down. So this is something between 4 to 6 during the normal childhood. And then during the growth spurt, it can go up to about 8 to 12 or 14 even, and then comes down, and then ultimately it will totally stop, because we know beyond a certain point, roughly about 18 years, we stop growing in height. And then this will also keep on growing, and by about 18 years, it will stop. So the line will become a plateau line because of the growth stops afterwards. So that is where we have to remember. Somebody had posed a question saying that whether the mother's milk could transfer glucose. Mother's milk can transfer glucose, but it will not be as high as the mother's blood glucose level. So there is filtration, but of course, high or diabetic mother's milk will not have very high levels of glucose that will cause alarming defects in the child. But of course, it can be little higher than a normal mother. So just remember that. But that does not have any bearing in our management, because we don't say that the mother has diabetes, so the mother can't breastfeed the baby. No, at least nothing like that. Mother can continue breastfeeding, and then that breastfeeding will not harm the baby also. So you continue the breastfeeding, although there could be large amounts of glucose in that, rather than in a non-diabetic mother. So the growth during adolescence, growth during adolescence, the prepubertal growth, mainly the limbs increase in size, and the pubertal growth, the trunk increases in size. Then in puberty, the changes occur in size, shape, and body composition. Now, gradually, during childhood also the size increases, shape also increases or will be there. But of course, the male and female shape and the body composition hardly changes during the prepubertal period or the childhood growth, because that is why we actually cut and grow the hair and give us gender identity socially to the child. If we cut the hair, both children, as very short, or if you let the hair grow in both males and females, there may be hardly any difference sometimes to identify the male figure from a female figure. Similarly, the body composition, if you take the fat content, then the muscle bone content in a prepubertal or child or during childhood growth, those two will also be more or less similar. But when it comes to the puberty, the shape of the body definitely changes with the change in the body composition. The females begin to deposit more fat in the body, and males will deposit more muscles in the body. So because of that, they will change in their body contour. The males will look more masculine, where the females will have a much more slender, feminine body shape. Also, the female hip area will begin to enlarge in order to give space for the uterus, as well as to accommodate a future pregnancy. Especially addition to the male, the female pelvic area has the uterus, which will enlarge in size, and that will help in the growth of the pelvic area. So like that, the shape and the body composition drastically change during the pubertal period. But of course, during the prepubertal period, the shape as well as the body composition hardly differs between the two. But of course, it will change during the course of life from 2 years, 3 years, 4 years, up to about 10, 12 years till the pubertal or pubertal spurts or the pubertal changes occur. But during the prepubertal period, the composition and the shape would be more or less same. That's why, more or less, if you see a child, sometimes you may not be able to differentiate unless the hair is differently kept, then the dresses are differently made, that type of thing. So that is why it is also important to give that gender identity from a younger age. Of course, sometimes psychologically they will have differences because of the hormonal priming that takes place. Because if you give to a girl, they would usually try to pick a female toys like dolls and things like that, or household cooking utensils. But if you give toys to a male, a jumble set, you will see that they will pick more vehicles, trucks, that type of things. So there is a little bit of a psychological thing, but physical wise, there would be not much of a difference. So that's why from outside, from the society's perspective, we tend to tell parents even to give the identity from a young age by making them wear male sort of type of clothes, cutting short the hair and things like that. So I hope that question was also there, whether there is a change in the body composition. There is no difference in the body composition between sex, but there will be gradual changes in the body composition because there is something called adiposity rebound, where the fat in both genders begin to gradually increase later. So the onset of puberty, especially menarche, is related to nutrition. That's why obesity causes leads to early menarche. Even in the males, of course, you can see that the fat males are initially tall, but later on they can become a little bit of short because their bone ages will mature little ahead of the lean counterparts of the same age. But mainly the clear change that could occur because in the pubertal growth, menarche is one of the key things that is quite clearly, obviously, occurs as a landmark point. So that will be earlier in well-nourished, what you call overweight, obese, or well-nourished children compared to their undernourished counterparts. So the onset of puberty would also depend on nutrition to a great extent. So then the adolescent growth spurt, as I said, the peak height velocity, males, it will be about 10 centimeters on average, but can vary between 8 to 14. Females, it's about 9 centimeters. So the peak height velocity occurs in girls early and in boys little later. So in girls, if menarche occurs, usually the growth spurt has now passed and the amount that they will gain in height is going to be less. But in males, that's why they have a little later, and even in males, you don't have exactly identification place, but their laryngeal break or becoming hoarse voice is almost the last point in their growth. So the changes that occur in the body composition in puberty is the muscle and the fat. Males put on more muscle, whereas females put on more fat. And the bone mineral density changes in both males and females. It increases, and it is very important that the bone mineral density is brought to the highest level. So how can you bring it is nutritionally the child should be sound, that is proper amount of calcium, proper amount of vitamin D should be there, and it's very important that they have the adequate physical activity because that will help to deposit more and more bone. So the maximum bone mineral density occurs around 20-22 years of age, and afterwards there will be reduction in the bone mineral density. So if somebody reaches the highest peak at that age, the chances of becoming osteoporotic at a younger age is less. So that's where to prevent osteoporosis, you have to increase the or have the highest bone mineral density at this particular time of life, because there is no point of taking calcium or iron, vitamin D supplementation later on. It will help a little, but it will not help to stop this. Then the total body water will increase, intracellular water will increase, red blood cells, hemoglobin, all these changes with the change in the growth of the individual. The main limiting factor of growth is the bone growth, because after 19 years or 18 years, we stop growing. That is because all the epiphyseal centers will fuse and there is no more cartilage. So the bone will be a rigid mass only. There is no room. So the linear growth stops at that point. So that is where growth will stop. So of different tissues will have different growth rates at different times, and they will stop growing after a certain point. You can see the initial ones that starts are the brain growth, which keeps on increasing after about, so the rapid growth occurs and completes 80% by about 3 years of life, 3 to 4 years. Then gradually the balance keeps on growing, and by about 12, 14, the total growth is stopped. Then the general, you can see there is a rapid growth initially because what has been occurring in the initial phase, and now there is a plateauing, and then again there will be a rapid growth occurring. So the general growth, so rapid continuation of the fetal growth, then the normal growth during childhood, and then the spurt that occurs during the pubertal period, which occurs during this period. And then the reproductive organs, very slowly they will grow in the initial, but more or less plateaued, and only at puberty they will grow and come to the 100% or the adult size. The lymphoid tissue, where people are now getting exposed to various infections, and you all know when children first year onwards, from birth onwards, they get exposed to different infective organisms, immunization, all that is there. So the lymphoid tissue is the main one which will keep the memory and response to the infection. So there will be increase, and they will increase more than 100%, or what is called more than the adult level. So then they will come up, they will fight the infections, they will retain the memory in few cells, and then the total tissue comes and lies at the normal 100% or the adult cells. So that is why the only tissue that will grow beyond what it is required is mainly to safeguard the individual, and that will come down. So you can see after about 10, 12 years, the infection rates in children will come down, because by that time they have almost exposed to many of the infections. They have developed a memory bank, so they don't have to have large cells. So sporadically, the lymphoid, if they get an infection here, if they have the memory cells will activate, come up, have some tissue, then will go back. Again, they will come up, they will go on. So later on, the tissue will be showing something like this pattern if you were to draw it. But of course, the brain, then the general, then the reproductive organ will keep on plateauing at the 100%. If not, they will gradually decline in size, because you all know even height will come down when you are old age because of the collapse of the vertebrae and the stooping. So if you draw it till death, if we say here, the brain also can get atrophic a little bit. Then the general condition or the height will come down also, and the reproductive also can come down, whereas the lymphoid tissue may have small ups and downs in order to respond to the infections in the environment. So then we discuss about the catch-up growth and growth regulation. Growth will take its inherent curve if all other factors are supplied. There could be a drop in the curve due to an acute insult like infection or famine, but after correction, they will get a catch-up growth and fall in line. So what happens is now the child will grow, and then, but later on in life, now I'm talking beyond the birth. Now in the birth, we saw during the intrauterine life, if there was some problem, they would catch up. Or if there had been overnutrition, they would catch down. But then they will settle onto a particular line, and they keep on nicely growing. But then all of a sudden, there is lack of food, either due to famine or the child had an infection, so he could not take enough. So his weight drops from 10 kilos to 9.5. Then he recovers from this insult, and then he goes back again to the original line, which were 10 or above that, which according to that line. So they will fall in line. So we have to make sure. So the important thing is we have to provide the optimum amount of nutrition. So we have to try to get the maximum out of an individual. If somebody is not given adequate nutrition, then one of the biggest problems that they would face is that they will not have a proper linear growth. Yeah, if any of y'all would have been 5 centimeters taller than what you are, I mean, surely everybody would like that. But we don't know whether there would have been a chance of getting that or not. So, but with the science and as being medical practitioners now, it is our duty that we make sure that we give the best optimum nutrition to a child and make sure that he will grow tall. So instead of becoming 160, if we can make him 164, that could have some more advantage in his life. Sometimes 1 centimeter, 2 centimeters may cost his childhood aspirations like joining the army or becoming a pilot or something like that, which requires a minimum height. So that way you have to make sure that they are given the best chance in life. So these are different inherent lines. So a child born here, always we can't say abnormal. This child may have had a lot of problems in the intrauterine, but he's keep on growing nicely. So if his mental growth is good, if he's not suffering from recurrent infections, then you don't have to worry very much. And especially if his weight is matching to his height, then of course that will be good, which we will discuss in the next lecture. So there will be different trajectories. So what is important is without much disturbance if the child is growing along these lines. So, but if a child keeps on growing high like this, then of course we have to find out whether this is acceptable or not. So it is important to see the trend in growth before making a comment. So somebody may see the growth here and then he will say, okay, normal, but actually the growth may be very high. So I will give examples in the next lecture. So this is what I was telling. So the child had a small growth and there was an insult. So he recovered from that, came back normal. So his normal potential is to grow on this line. But of course, what happens is there had been some small illness. So the growth begins to falter. It is growing, but it is not at this rate. It has come down. So the child should be this much of weight, but at the moment he's just only, he could have been 8.5 kilos. He's only 8 kilos. So that keeps on growing. And we are not looking into the reason for this. Then what happens is at one point he stops growing. He just keep in the same weight. Then what will happen is if we don't do anything, he will lose his weight. So that is weight drop. And then only we realize and we correct it. It may be poor nutrition, it may be some other infection. We treat that. So when we treat that, then he catches up. So this is now he goes back into this original line. So when you go back into that original, this process is catch up. So this is late catch up. This is an early catch up. Now this is not mandatory that everybody should have because it depends on what really caused them to be small. But this is, of course, we know that the baby can grow along this line. He has proven that, provided that the child is given the proper nutrition. But there was some problem, and then the weight dropped down, and now as a result, the child has, so now we can't let the child grow along this, no, because that is not fair. So when the weight is also growing like this, his height will also grow somewhere closer to that. So that is not acceptable. So we have to correct that, get the fellow up, and then let him catch his what he has lost. So this is catch up and coming back to his original state. That is what is called catch up growth. Now, any questions up to now? There were few, I think I will take it up. Then, now factors affecting growth. Now we just talked about normal growth and how at different phases it has been contributing. What are the factors, that is intrauterine, what are the things. Then the postnatally at different levels, nutrition, growth hormone, then the sex hormones, like that. Now we look what are the relevant factors actually. Now the clinical observation in relation to growth disorders is size at birth and antenatal factors. So you take a history and find out what had been happening inside the uterus. Then the nature of the growth in the infancy and childhood. Now sometimes what happens is, now when you are managing a patient, a 3-year-old, 4-year-old child will be brought. And then you have to see, okay, the child. So you have to make sure and look how the child had been growing at different stages in life, because this is whether this is the ability of the child. Now, if the child had been growing at -2 line, keeps on growing on that, although the parents come and say, because sometimes what happens is the child will be looked after normally and growing. And when they go to the Montessori or they go to school, then the parents will notice, okay, my child is smaller than the other children in the same age group. Then they will bring to you. So then you have to see whether this had been a recent thing or whether this had been a thing that is coming. So then you will see, okay, there are certain factors. So you have to see what had been the during antenatal. If the mother says, okay, I had a lot of vomiting, and then I was feeling unwell and I had got some other illness, then the potential for the child to grow would have been very low. So he did not grow adequately. Then the nature of the growth in infancy and early childhood you have to see. Then you take the CHDR, see what had been plotted, and go on. Then inheritance and family factors. So you will ask whether the what had been the family like. You will look at the parents, whether the mother is short, whether the father is short, like that. Then nutritional status, you can take a, then the general health, whether the child had been falling ill very frequently, things like that. Then hormonal changes, you will do a quick examination, see whether there are features of hypothyroidism, features of Cushing syndrome, or anything like that, or if you suspect any growth hormone deficiency, things like. Then how is the home environment? Psychological, psychosocial, and emotional aspects are also very important. If the child is very unhappy throughout the day, the stress will be there. How much he gets food and other things will be immaterial. The child will not grow properly. And whether there are any particular syndromes, whether the child has features or Down syndrome or any other dysmorphism, and that can affect the growth, have to be looked. So size at birth is the height and distance disease states of the mother will influence the size of the baby. Then the genetic factors begin to show up after birth. So you will, that's what I said, you will ask what had been the any family history of short stature or whether the mother and the father size. Then by about 2 to 3 years, the length settle into the inherent line. Even weight will do so, mainly the height. Therefore, there will be a catch up as well as a catch down by crossing centers to settle the west, which we discussed earlier. So the nature of the growth in infancy and childhood, antenatal and first 2 to 3 years, the growth will settle into the inherent line. Then mainly wheat flour like thing, they will develop diseases in the intestine. So as a result, they can't absorb food. So you will see the weight had been nicely going till about 6-7 months. Then it begins to drop. So, so the insults can be malnutrition, undernutrition, neglect, social deprivation. So if they occur in older children at the first time, would be able to reverse it. So it depends on the time that they are going to occur. If it is occurring in a later stage, you can easily reverse it. But sometimes in the early stages, it may pass on without being detected very much, and only later they will pick it up. Then familial factors, predominant influence on growth within the population is inheritance. Inheritance will influence mainly the height, degree of the fatness and thinness also, because sometimes there will be familial obesity, which will affect them. Then even the pubertal, if mother had attained menarche early, there is mostly their child would also attain early. Then if there had been constitutional delay, that is in the growth and maturation, that is the father, mostly it is seen in boys, that till about 16, 17 years or 16 years plus, the male will not gain the growth spurt as well as the pubertal growth changes. So if you go into the history and ask, the father may also say there will have been a delay. So one of the main factors you can ask is whether the father could remember when he had his first shave. So if he says, I had it after my ordinary level exam or whatever, then you can get a rough idea of the pubertal age that the father got it. So like that, the male child would be strongly affected in the constitutional delay, but advancement is strongly affected or in comparison with the mother's menarcheal age. So the child's expected height centile can be calculated by the what is called the mid-parental height. That is the mother's height and then the father's. I will discuss that later. So you can get the height centile by seeing what is the father's height centile and the mother's height centile. But more than that, the expected final height can be roughly calculated by, for boys, you get the father's height and then the mother's height and add to 12.5. Whereas for girls, you get the father's height, deduct 12.5 and add mother's height and divide by 2. So that will be the probable final height, but you can add about 8 centimeters plus or minus and give a range. So if the final height comes as 160, that means the child would end up something between 152 to 168 range. So that way you will be able to find out what is the mid-parental height and what is the height range that the child is going to achieve. So that's why I said, if the parents come and say, my child is very short, you have to invariably see whether the mother and the father is short. And then you have to calculate and say, okay, yes, both of you all are short. That is why the child is short. But according to matching to your height, the baby is growing quite okay. So like that, you have to get it. So the nutritional status, which you all know, then the general state of health, chronic illnesses will affect. Now, if the child is having some long-standing illness like renal disease, or the child has a heart disease, then the child will invariably not grow as the other children. So you don't see that there are people losing height, but the rate of height gain will be low. Even treatment sometimes will affect, especially if you give steroids, prednisolone, then their height velocity will come down. So the disease as well as the treatment given for diseases will affect the illness or will affect the growth of the individual. Then many hormone conditions lead to adverse growth. Usually weight acts in an opposite direction to height. Most of the hormonal problems, the weight and the height goes in the two different directions. Now, for example, if you have hypothyroidism, the person will put on weight, but the height will not grow. So they will be short, obese. Similarly, if there is growth hormone deficiency, it will be again a short, obese person. If it is thyrotoxicosis, it will be thin, tall person. So like that, the weight and the height in hormonal disorders move in the opposite directions. So the endocrine short causes are short growth hormone deficiency, thyroid deficiency, glucocorticoid excess, and then sex hormone deficiency will cause delay in production and short stature early, excess premature production, short stature, and ultimately short. Now, this is growth sex hormones will have a little bit of tricky thing, because sometimes you will have, now we know sex hormones causes a child who is deficient in sex hormone will be short initially because now he is supposed to secrete his sex hormones when he's 12 years, we'll see. But this child is secreting the sex hormones only at 14 years. But the other his or her friends will be secreting at 12 years. So with the 12-year growth spurt occurring, those children will be very tall. And also you have to remember that once the growth spurt occurs, they will stop growing. So they have now stopped. Now the child who did not attend puberty, did not get the sex hormone release at 12 years, is now releasing only at 14 years. Now he grows into the growth spurt. His levels are all normal, so he gets the same amount of height velocity. He was initially short because his friends at 12 years was growing rapidly. When he was growing about 4 centimeters a year, his friends were growing at 10 centimeters a year. But it stopped after 2 years. Whereas this boy now till 12 to 14 years, he gained 2 additional 4 centimeters each year, because he was still growing, because his bones have not stopped now. So then what happens is he gained 10 centimeters at his 14 years, the normal growth spurt. So he also got the 10 centimeters. His friends also got 10 centimeters. But the short fellow or the delayed puberty person got 8 centimeters in excess, because he was still growing while the other people have stopped growing. And then as a result of that, if we take it at 18 years, the delayed puberty person is now 8 centimeters taller than his counterparts. So the delayed sex maturation has an advantage, because they will have natural growth happening during the period where they were not getting the sex hormones. But early matures will get the early puberty, early growth spurt, and they will stop early as well. So that is something you have to learn. So this is one of the main things that will happen in the constitutional delay. The child will be brought 14 years or so. That's saying all his friends are tall, but you examine his pre-pubertal, then you do a bone age, he's not matured. So then you don't have to worry, because he will grow into growth spurt sometime later and he will be tall. But those who actually prematurely mature, now for example, there is what is called precautious puberty. At 8 years, 9 years or so, they will secrete sex hormone. They will be very tall. So parents will be also very happy, because this child is very tall. He or she is the tallest in the class. But of course, she has also developed pubertal signs. And now you can see somebody who has developed the sex hormone related growth spurt at 8 years will stop growing by 10 years, whereas his or her friends keep on growing till about 12, 13, the normal growth, and then get the growth spurt. So that child will be about 10, 12 centimeters short, because he has now stopped the normal growth, and then she has lost that growth. So early growth maturers, if they come and say the child is very tall, you have to make sure that you quickly examine, see whether they have gone into precautious puberty. If they have gone into precautious puberty, you have to immediately give medicine and stop that. So you have to send it to endocrinologist, get a full assessment, and we have to stop the growth spurt, because otherwise what will happen, this child will end up as a very short child during adulthood. So that means that will affect the next generation, because the pelvis will be small, a uterus will be small, so she will deliver a small baby, and like that. So you can see some of these growth factors that affects one generation has the repercussions on the next generation as well. So these are some of the things you should know as a first contact doctor. If things are happening earlier than what it should happen, that is an alarming sign, and you have to take action. So then diabetes mellitus also can cause short stature in a way. Then hormone, the endocrine causes of tall stature, growth hormone excess, thyrotoxicosis, sex hormone, precocious puberty. They will be tall early, but of course they will be short later. And extreme delay, they will be tall, short initially, but they will be tall ultimately. So psychological and psychosocial and emotional aspects of growth, you all know that. Specific syndromes are there, Down, Silver, Russell, Turner, Noonan, fetal alcohol. All these will cause a short stature in the individual. Similarly, there are syndromes which cause tall stature like Klinefelter, Marfan, and Soto disease. So that is for the growth lecture, normal growth and factors affecting growth. If I quickly go through the questions. During childhood, there are significant. So if there is any influence on preventing secondary amenorrhea with level of body fat in girls, is there influence in preventing secondary amenorrhea with a level of body fat in girls? Secondary amenorrhea occurs due to what reason you are talking about here? Kasturi Arachi, would you mind talking? Hello? Can you hear?
Yes, sir.
Yeah. Now, is it your question?
Yes, sir.
What is there in your mind? Why did you ask this question? Easy for me to explain.
Sir, with body fat increasing, is there any influencing girls who are facing like secondary amenorrhea?
Yeah, that is what I'm asking now. What do you know about the body composition of excess fat and